Jeanie, it would be hard to have a conversation about risk management without talking about the medical record. Can you talk to us a little bit about telling the story from the risk manager's perspective?
Absolutely, and you're right, Ed. There's nothing more important than the medical record documentation. In fact, when it comes to defending a medical malpractice claim, the medical record can be your best defense or it can be the strongest evidence against you. A well-documented record may not support a liability claim. A plaintiff attorney may walk away from a potential claim if the quality of the medical record documentation is really good.
Jeanie, in the last 10 years, we've seen the evolution of the electronic medical record. What sort of challenges has that posed?
There are many, many challenges posed by the electronic medical record. There are certainly advantages to the electronic medical record, and of course that depends on the EMR that you're using, but certainly there are triggers, and they do help physicians to remember important documentation that they might have forgotten if they were just dictating or handwriting a record. However, there are also a lot of unintended consequences. When we look at a record, you don't want to look at the record and right away know that it was created electronically. You want it to appear to be as closely to handwritten or dictated as it can so that it seems natural and it's a logical progression of care. And the one thing that you really don't want to see is that the record reflects an exam that the physician didn't perform. And that can easily happen by a physician just clicking on something inadvertently, and the record says that they did an ENT exam when they didn't actually do one. You don't want to be in a situation where you have a patient telling a jury that the physician never looked in their ears when it's documented in the record that they had a normal ENT exam. So those are things that you want to avoid, and make sure that you're aware of every click that you're making so that you can not make any careless clicks that end up in information in the record that's not true. Creating a medical record that's accurate and complete, a complete reflection of the ED visit is of course one of your primary responsibilities. And you want to make sure that that record reads like a storybook that leads the readers to only one possible conclusion, yours. Medical records are a determining factor in more than 80% of malpractice cases, and of course that's not in favor of the physician. Documenting a medical record is of course a learned art, and some physicians, as we know, are really, really good at it, and others struggle with creating a quality medical record. I think that the groups would be well served to identify the physicians within their group that are really good at documentation and find out what the rest of the physicians can learn from them.
If I could add to Jeanie's thoughts, there are several common errors that would be helpful to point out, and these are all from actual malpractice claims from emergency physicians, and show the value of reviewing charts and looking at each other's work. So some of the common themes we see are omissions in history and exam. Let me give you an example. I recently reviewed a claim that was a missed fracture, and the chief complaint was leg pain from a bicycle accident. So when I looked at the record, first thing I noticed in the history is there was no mechanism of injury, and there was no leg exam. So you're kind of, your hands are tied behind your back from the get-go. So as it relates to the chief complaint, got to have a thorough history and a detailed exam. I think another area is risk factors, and they can be readily identified, like pulmonary embolism, chest pain, ectopic pregnancies. All of those things should have risk factors, and if you're evaluating a patient and that's in your differential diagnosis, you need to consider those and document them. Vital signs. Vital signs are very important to not only write them down, and if they're abnormal, but you need to decode them. You need to tell about what your interpretation of those vital signs is. Was there a change in them? If you gave therapy, did they get better or did they get worse? I think response to therapy, particularly now as we have patients that are waiting many hours in the emergency department, is critical. And I'm not talking about reams of dictation and pages, but just a quick note with a time that says you went and reevaluated the patient. And that also shows decreased risk, the value, particularly on things like abdominal pain, of serial examinations. Pertinent positives and negatives are very important. History of prior episodes, has the patient been seen or treated? In a differential diagnosis, we want to make sure we exclude high-risk diagnosis. The last two things I would add are just very important to document accurately in a objective manner, and our discussions with consultants, and the dialogue that happened between, and and the decision that resulted from that consultation. And last but not least, we call it the last chance to get it right. In fact, you can do everything wrong up to that point in time, but the discharge instructions really should be language specific, pre-printed, and discussed with both the family and the patient. And we know from studies that even if we do all those things, we only get 50% compliance. So very, very important to have specific discharge instructions, close the loop on your documentation, and ensure good follow-up.
So, Graham, what you've just talked about is, it sounds like all of this is complex. There's a lot of stuff to remember. Jeanie, is there any way that you can give us some risk management pearls that'll allow us to sort of summarize the best way to do this?
There are a lot of tips, and we could probably talk for a long time, but just to give you a few, I think it's really important for ED physicians whenever they can to document in real time. And I don't mean that they have to document while they're in the patient's room, though some physicians have employed that practice. But certainly you don't want to wait until the end of your shift and then be documenting on 30 or 40 or 50 patients. And worse than that is to wait until your next shift, a day or two later, and try to remember what happened and sort everybody out. You want to make sure that the ED course is well documented, and especially patients that are sicker and more complex, and those that have a long length of stay in the ED. Graham mentioned, the importance of serial exams and documenting that you went back in and checked the patient. Those are really important tips. The other thing is you want to address discrepancy between providers. You can't avoid them. Nursing assesses the patient and they document what they see, but you need to make sure that you read their documentation, and not every physician does religiously read the nursing documentation. But if the nurse has documented, for example, that an infant has petechiae, you want to make sure as the physician that you address in your record that you didn't see petechiae and what you did say. And lastly, the medical decision making, and Graham talked about this, but this component is the most critical part of the chart. It really tells what you were thinking and why you did what you did, and you want to make sure that that's very, very well documented. But Ed, you're still a practicing physician. You're slugging it out in the ED shift after shift. We'd be really interested in your opinion on the various modalities that are used for documentation.
I have the advantage of practicing for the bulk of my career in a department that is now in its almost 12th year of electronic medical record that we helped develop, and so we've helped build in a lot of the things that both of you have discussed. But some of my work today is in departments that still rely on documentation methodologies that are old. We still have handwritten charts. We have some departments that have moved to a templated type of chart, a chart that relies on really using checklist type format for documentation. And then still the minority of departments that have electronic solutions. I think each one of those have challenges that the practitioners in those circumstances are going to have to face. When you are handwriting a chart, whether you do it that way, whether you are dictating a chart, there is the challenge of just free-form text that sort of rambles along, and then you get all the interruptions that come with your day-to-day work that disrupt the flow of how the story is being told. The templated charts sort of guide you through the documentation, but oftentimes aren't as successful at simply telling a story. And we also have a number of departments in many of our client hospitals for EPIC where scribes are being used, and the scribe ends up being an interface between the documentation and the physician, freeing them up to do more direct patient care. But what that implies is that there is a third party in the midst of the documentation process, and if the practitioner isn't diligent about reviewing what has been written and taking ownership of the final product, there is an immense amount of risk associated with that. So the documentation strategies, the processes involved have many, many challenges that we are left with. I think if at this point I could say that a final note for practitioners is if they viewed every medical record as their own small movie script that they had to write, where there was a flow that had to be attended to, there were documentation elements that had to be attended to, and there had to be an overall story that was told that reflected the care that was given and the decisions made, that would leave people with the greatest protection for themselves and their patients.